Thank you. I think you're going to be very excited to meet our next speaker. Dr. Christina Donnellan is a consultant geriatrician at South Tipperary General Hospital. And again, I've just met her, but I'm really struck by her composure under pressure and her focus on prime objectives. And isn't that something that we've begun to talk about for the first part of the morning, that we need to keep our priorities in order. And too often in healthcare, we can become distracted by the trend of the moment or the technology that everyone wants to try out. But one of the things that impresses me about Christina is that her empathy and her focus really come to the fore, particularly under pressure. That's something to be treasured in a world where there's a lot of information, but relatively little knowledge and wisdom at hand. So for the next 40 minutes or so, let's extend the conversation that we've been having about frailty and aging and older people with Christina Donnellan. Thank you, Christina.
Thank you very much. Thanks for your very kind and generous introduction. Thank you, Mary, for inviting me to speak at this conference. I'm quite honoured to be here with your esteemed list of speakers and to meet all of you here who are interested in frailty today. So, to start with, how do we see frailty? So, all of us have an opinion of what frailty might feel like or seem to us. So we might think of it as, you know, can't do anything, skinny, bony, doddery, shaky, and so on. But what is it really? So it's a clinical condition which is very challenging today. It's one of the most challenging consequences of the ageing population. So it's a state of increased vulnerability that occurs because of a decline in physical and psychological and reserves. Resulting in an apparently small event causing a dramatic change in physical and mental well-being. How is it detected? So there are various ways of identifying frailty. Broadly speaking, there are two different methods. One is identifying frailty syndromes. So on the left of the slide, you can see a list of frailty syndromes. So those of you who've worked in care of the elderly would be very familiar with these. In the past, when I was training, they were called geriatric giants. So, for example, falls is listed there, immobility, reduced mobility, delirium, which is otherwise known as an acute confusional state, incontinence of urine or feces, susceptibility to side effects of medications. So in particular, for example, patients becoming confused because of the side effect of a toxic medication, having an excessively low blood pressure because of treatments for blood pressure, antidepressants, and many other medications. Okay, an alternative way of identifying frailty is by using a frailty assessment tool. And there are many of these validated tools available. So you can see a list of those tools on the right-hand side of your screen. So to highlight in more detail what is involved in assessing frailty and what the components are, you can see on this slide the Edmonton Frail Scale. And on the left-hand column, you can see the various components. So as part of this Frail, cognition is assessed. That's by asking the person to fill in the numbers in a clock and putting in the hands to show the time at 11:10. And then the patient is scored depending on their accuracy. So other domains are their general health status, their functional independence, social supports. When you need help, can you count on somebody who is willing and able to help meet your needs? The use of medications, nutrition, mood, continence, and functional performance. And at the bottom of the screen, you can see a scoring system which identifies whether the person is not frail, vulnerable, mildly frail, moderately frail, or severely frail. And what's the significance of identifying frailty. How does it present? So it occurs, as I mentioned, in somebody who has reduced physiological reserve and perhaps has some of those frailty syndromes. But in our current health service, often persons with the frailty syndromes are not recognised as being frail. So their first presentation is often when they have a stressor event. So perhaps an acute illness, perhaps arthritis, something happens and it leads to a decompensation. So they may present with falls, immobility, incontinence, changes in cognition, and iatrogenic, meaning healthcare induced, for example, inappropriate prescribing of medications. And this then leads them to require increased care needs and often admission to hospital, and in some cases leading on from there to long-term care. So on this next slide, you can see the impact of frailty on the person when they have an acute illness. So there is a horizontal dotted line, and below this line depicts dependence, and above it independence. So the green line then represents you or I, somebody who might not be frail, who gets an acute illness. So you can see that when you get an acute illness, your function might decline temporarily. You might not feel well, you might have to go to bed, you might not be able to go to work, but you recover fairly quickly and resume your normal activity. But in the person who is frail, when they get an acute illness, there can be a dramatic drop in function, such that they become dependent on others for their care needs. This loss of independence can be quite prolonged, and they may eventually recover, but may never recover to the level in which they were functioning before. So it's quite a serious condition, this frailty, and the impact of it is quite dramatic. This slide similarly depicts what happens in the setting of an acute illness. There can be a dramatic drop-off in functioning. So in the acute hospital, what do we see? We see people who have dementia, depression, infection, arthritis, pain, falls, polypharmacy. There are multiple problems presenting because of frailty. A newer concept is of cognitive frailty. So this is characterised by the simultaneous presence of both physical frailty and cognitive impairment, but not necessarily in the presence of dementia. And it has potential for reversibility. So how common is frailty? Well, the answer is that it is very common, especially as you get older. So if you look at the bottom blue line on the slide, this relates to people over the age of 75 years. So you can see circled the number 36.4. So this is the percentage of people over 75 who have mild frailty and are at risk. To the right of that, you have 20.5% of people with moderate frailty, and a further 11.3% have severe frailty. So that's a very significant number. Even when you look at age over 50, you will see that about 13% of people are frail, and it increases with increasing age. Then when you look at the acute hospital setting, where many of these patients present for the first time and come to the attention of the healthcare professionals, frailty is very common. In a study done recently in Mayo University Hospital, where they screened all older patients over the age of 80 years presenting to the emergency department, 96% had a frailty syndrome. And a number of years back in South Tipperary General Hospital, we screened our attendances in the AMAU over the age of 70 years, and we found that 94% of them were frail. So I'd like to play a video for you of a particular patient case, a lady who was frail, 84 years of age, who fell, and whose outcome was not as good as perhaps it could have been. So I just have to see how to play it. Sorry. My laptop is very old, and so whilst it worked fine on my laptop, oh, thank you. It's not any laptop, it's me.
When I had a fall in the bathroom, my husband called the out-of-hours doctor, who told us to call 999. Arthur couldn't help me get back. Story of my trip to hospital.
Mrs. Andrews' story.
It started one Friday evening when I had a fall in the bathroom. My husband called the out-of-hours doctor, who told us to call 999. Arthur couldn't help me get back up on my feet. I had a nasty bruise over my right hip. I wasn't keen on coming into hospital, but they persuaded me.
I was on call when Mrs. Andrews was brought in, and I arranged a hip X-ray. There was no fracture, but some blood and urine tests showed that she was a little dehydrated and had a possible water infection.
Mrs. Andrews was moved on to the acute medical unit. She was getting close to breaching the 4-hour target. It was also getting late, and the AMU was a safer place to assess her and get her back on her feet. We put up a drip and gave her some antibiotic tablets for the urine infection. On Saturday morning, she was seen by the on-call medical consultant. Before we could look at her mobility, the patient flow team insisted we move her to the first available medical bed. She was not reviewed again medically till Monday. There is no routine physiotherapy or occupational therapy over weekends, so we couldn't refer her to the home rehabilitation team before then. By Monday, June had been on either a trolley or in a bed with the cot sides up for 3 nights because she was deemed to be at high risk of falls, and the nurses had inserted a urinary catheter. She was seen that Monday morning by the physiotherapist, who got her out of bed with the aid of a Zimmer frame. My home ward is in the elderly care unit. We do our best to provide a regular liaison service to other wards, although we wish the doctors there had more knowledge about managing older patients. The ward doctors and occupational therapists made a plan to get some more information about June's usual abilities and past medical history.
I'm June's husband. On Monday, I was able to get back into the hospital to see her on the ward. I told the ward doctors and nurses that June had been getting more unsteady recently, had suffered another fall, and that her memory isn't what it used to be.
The review team discovered that her blood pressure was dropping very low when she stood up, postural hypertension. It often leads to falls and faints in older people. We stopped a couple of her cardiac medications to try and solve this problem. By Wednesday, she was able to stand with assistance. The physios came to see her, and a plan was made to refer her for ongoing rehabilitation in the local community hospital before going home. But not for the first time. There were no community beds, and by the 10th day of June's admission, the cardiology ward desperately needed beds for acute cardiac patients, and she was moved to a winter escalation ward. After all those moves, Mrs. Andrews had become confused and agitated. She had another fall, sprained her wrist, and now she required 2 nurses to transfer her from bed. June spent increasing time in bed with the cot sides up. By day 12 of her admission, the community hospital phoned back saying that she had no rehab potential and should have a care package instead. She was referred to social services with a target discharge date for Friday, but the package couldn't be put in place till the following Tuesday. She went home with a 3 times a day care package, but with no clear diagnosis for her progressive memory impairment and falls. 7 weeks after her discharge from hospital, June had fallen twice more. Her memory was worsening, and Arthur was becoming stressed, concerned, and exhausted. June ended up being admitted for respite to a local care home. Mrs. Andrews never got back to her own home after her respite. We should have more care and support for older people like her outside hospital, and those services need to respond much earlier to people's needs. But the way we treated her in hospital and our difficulty getting her back on her feet and home again didn't help. With so many frail older people coming into hospital, we have to get this stuff right for everyone.
Okay. So that's quite disturbing to watch, really, isn't it? I mean, when we watch this story, we can all see that there are problems with how she was looked after. But unfortunately, it's commonplace. So, what kind of things went wrong? I think we can all see that quite a lot of things went wrong. But strictly speaking, I suppose recognition of frailty is one of the issues. That this was a lady who was frail prior to coming into hospital. It hadn't been recognised. She hadn't been screened. Her medications hadn't been reviewed. So there was no plan made with her husband. Her husband wasn't educated on frailty and what to do if she fell. When she got to the hospital, there was no appropriate frailty area, no early access to therapy. Escalation wards are bad news for all patients, especially for this type of patient. Every ward move increases the length of stay by 2 days, at least. Went home without a care plan, no shared record. The hospital staff were working hard trying to find out what was happening at home. It's possible the GP didn't even know she was in the hospital. And no re-enablement services on her discharge. You could comment on many more, including the cot sides, the urinary catheter, and so on. But in our healthcare system, we do hear the voices of older people. And this report on listening to older patients highlights some of these. So, for example, a gentleman spoke about having a fall at home. He had a fracture. He spent 1 month in hospital after theatre. The nurses all worked very hard in that unit, and the food was very good. He was subsequently transferred to another hospital afterwards, where he said he had excellent care and he had bath for the first time in months. Another man spoke of his wife's admission to hospital in severe pain. He said they waited 3 hours to be seen by a doctor. 3 days waiting for transfer to a specialist hospital. On a trolley, with no blankets or pillow. It was like a war zone. Put into a small room, like a dungeon, with no call bell, and it was very dark. She resorted to calling 999 from the room, asking where she was. Then got moved straight away to a bed. In recovery, sent to a clinic and had her medications increased, and then sustained a fall attributed to multiple medications. So you can see the experience is far from ideal. Of course, there are good experiences too. So there are risks associated with hospitalisation. We all know that, but especially for the frail older person. So apart from the conventional risks such as falls and so on, hospital-acquired infections, often there are other problems such as poorly planned discharge, care transitions, communication between facilities, the onset of delirium in hospital, immobility, incontinence, malnutrition can occur, institutionalisation, decompensation, and often because of pressure on beds, premature decisions about future care needs in the wrong setting. Of course, there is also a lot of adverse publicity that relates to frail older persons. So apart from the report of the Mid Staffordshire NHS Foundation Trust, we've had Lee's Cross report in this country. But there's a lot of publicity, and we will be seeing it for the winter, about our A&E crisis and about patients on trolleys. And older persons, and as I said, majority who are in hospital are frail, are often seen as a big part of the problem. And they're even described by derogatory terms such as bed blockers. So, what is compassionate care in the setting of frailty? So there has been a lot of interest in frailty in recent years, and a number of reports have been published. This one was produced by the NHS in 2014. And in this one, they highlight what the elements of care are for a frail older person, from healthy, active ageing and supporting independence, living well, etc., rapid support close to home in a crisis, good acute hospital care when and only when needed, good discharge planning and post-discharge support, good rehabilitation and re-ablement after acute illness or injury, high quality nursing and residential care for those who truly need it, and choice, control and support towards the end of life. And really, they're the components of integrated care for older persons. So the patient is at the centre of all of the discussion and planning. So here in Ireland we have the National Clinical and Integrated Care Programme for Older Persons, which was published recently. Prior to that, we had many previous reports outlining what care needs for elderly people should be and how they should be delivered, including the report in 2012 into the model of care for specialist geriatric services. In the UK, there have been a number of reports published also, including the Commission for Hospital Care for the Frail Older Person, and NICE have also published guidelines. So where do we start with it? Well, frailty education and awareness of frailty is very important. So there is a national frailty education programme through the National Integrated Care Programme. And so currently nurses are being trained, and we have some nurses in the room who are engaged in this training and who will be trainers to train others. But ultimately the plan is that all relevant healthcare professionals will receive frailty training. So who should be screened? Well, opinion seems to be that people over the age of 75 should be screened. But that it's an arbitrary number really. It could be over 70, depending on resources and so on. And where should the screening occur? Well, it should occur really throughout all healthcare settings, including in the home, the GP surgery, the emergency department and clinics and so on. And who should do the screening? Well, the healthcare professional who's dealing with the patient, so it could be nursing or it could be another other healthcare staff. And what test should be used? Well, any validated screening test, including those mentioned earlier, or you could use an electronic frailty screen. In the NHS, there is an electronic frailty screen, which I understand they are rolling out, and there is a plan, I understand, for GPs to do electronic frailty screening on their population over a certain age. And what does it lead to? So if you find that somebody is frail, well, the hallmark of good care for a person who's frail is a comprehensive geriatric assessment. What is a comprehensive geriatric assessment? It's an organised approach to assessment designed to determine an older person's medical condition, mental health, functional capacity and social circumstances. So its purpose is to coordinate and develop an integrated plan of treatment and rehabilitation, support and long-term follow-up. So there are many elements to a comprehensive geriatric assessment, or CGA. No one size fits all. However, there are 4 key areas that should be assessed. So there's a physical assessment, a functional assessment, psychological assessment and a social assessment. So the physical assessment is usually done by a geriatrician, but the various assessments can be done by differing members of the multidisciplinary team depending on the relevance and resource. So it is extremely important that the person has a medical assessment to determine why they may have become frail, because frailty may be reversible. It might be anemia, it might be an infection, it might be gout, it might be Parkinson's disease that could be treated. So that part of the assessment is very important. Also, as part of it, medication review and reconciliation is recommended. and we might find that the person is on medications that are causing cognitive impairment, for example, or that blood pressure is overtreated. They should have their nutritional status assessed. Alcohol is important. Immunisation status. Advanced directives. The functional assessment then involves assessing activities of daily living and looking at balance and mobility. Their mood and cognition should be assessed. And the social assessment is as important as the others. Their living arrangements, their social supports, care, stress, financial circumstances, and the living environment. So who carries out the comprehensive geriatric assessment? So it's a team-based approach from medical to nursing, social worker, physiotherapy, occupational therapy, speech and language therapy, dietetics, pharmacy and podiatry. So a whole range of people could potentially be involved in an assessment. So what are the benefits of doing a comprehensive geriatric assessment? So the evidence is that if a frail older person is admitted to an acute hospital, they should be admitted to a specialist geriatric ward with a specialist geriatrician-led multidisciplinary team and have a comprehensive geriatric assessment. There is substantial evidence then that those patients who receive a CGA in hospital on a specialist geriatric ward are more likely to return home, less likely to have cognitive and functional decline, and have lower mortality rates than those who are admitted to general wards. So we have some Irish evidence. However, it relates to 2010. So at that time, although we have had some specialist geriatric services, there might not have been early access to a multidisciplinary team depending on resources. But nevertheless, when you look at the column on the left, what we're looking at is, for example, length of stay. So the length of stay for patients who are discharged alive from hospital, if the person was admitted under a geriatrician on call versus a non-geriatrician on call, the length of stay is about half. And the length of stay of patients discharged alive from hospital, excluding nursing home discharges, also is less if the patient is admitted under a specialist geriatric team. The patients admitted from home and discharged to a nursing home are significantly less. The ED repeat attendances and readmission rates are look slightly reduced, but not significantly so. So the National Clinical Care Programme for Older Persons Services recommends the following: that you have a frail elderly pathway. I'm not sure that it projects very well, but I'll move on to the next slide, which is a model of how we think this might work locally. This is a project which is in progress at the moment. So we are trying to define a frail elderly pathway for our patients when they present to ED. We mapped what happens currently, and it's interesting to see how many times the person has to give their story when they present to a hospital, and how many different people they see. So in order to try and streamline the service, our plan would be that the ambulance service would alert us that a frail person is coming into hospital. So as they do for trauma or for stroke or for myocardial infarction, they would be aware that the person is frail because of the record that the person would have in their home if they were known to be frail. And so the caseworker or advanced nurse practitioner would be alerted, and also the specialist team. And when they arrive in ED, they would be triaged, and some might need to go to resuscitation if they have an acute illness such as a heart attack or shocked or whatever. And if their triage is not as acute as that, they would go to a dementia-friendly designated assessment area in the hospital where they would have access to a specialist geriatric team. And that would happen reasonably quickly, within an hour for a medical assessment, and within 6 hours they should have early assessment by a specialist team. This would then facilitate, hopefully, early discharge for some of these patients, or if they required admission to a specialist geriatric ward. If they could be discharged, they might be able to go home on an early supported discharge and have access to community rehabilitation and enablement services. So other developments in terms of looking after frail patients is having an environment that's suitable for people who have frailty, in particular cognitive frailty. So we know a lot more about the type of environment that's required, that you need to have clear signage, because often in a hospital setting all the doors look the same, all the walls look the same, and so it's very, very difficult. Can you imagine if you were in a hotel that had no numbers on the rooms, how you'd find your room? It can be extremely difficult for people to find where they're going. And in South Tipperary General Hospital, we're using this yellow butterfly to identify persons who have delirium or cognitive frailty. And we have a pathway for those particular patients. Specialist ambulatory care is also very important for these patients. So really trying to avoid hospital admission, because we know the risks associated with hospital admission. So trying to manage people in their own homes and having access to excellent ambulatory day services. So in the National Clinical Care Programme, they have designated the day hospital as being the hub for all acute ambulatory care. So that rather than admitting the person, you might bring them back the next day for a full workup with comprehensive geriatric assessment in a day hospital, particularly if they present out of hours, or ideally not present to the hospital at all but be referred directly in there, and from there have access to information and referral onwards to other specialist services, be it memory clinic, Parkinson's clinic, or Falls Syncope clinic. So I just want to mention social inequality, because that's a very important parameter. And this slide is just showing perhaps what we know already, but it is quite significant that social inequality leads to poorer outcomes. It leads to higher mortality rates and premature mortality compared with people who are not deprived. Because it is an important factor in our older patients. Often we see their housing is poor, they have very little financial means and suffer as a result. So what should the future look like? And this is from the National Integrated Care Programme for Older Persons. So rather than talking about the frail elderly, we should be talking about older people living with frailty, which implies a long-term condition. So, and rather than presenting late and in a crisis, that there would be timely identification for prevention, proactive care by personalised care and support planning. And that hospital-based care, rather than being episodic and disruptive and disjointed, that it could be community-based, person-centred care with supports, but obviously it doesn't eliminate the need for hospitalisation, and hospitalisation should be much more streamlined and integrated with the community. So coming back to our Mrs. Andrews, could there be an alternative pathway for her then? Well, of course, the answer is yes, that ideally, prior to coming to hospital, she would have fallen into the category for a screening assessment for frailty, and frailty might have been detected, so she should have been referred then from there for a CGA. So then her husband would know that she's frail. Because what we see time and time again is that somebody comes in who was clearly frail and who's in crisis, and the spouse and family say, but they were driving last week, you know, and so they're absolutely shocked and can't come to terms with a huge change. But of course the person was frail, and that's why it's happened. And the implications for the patient and family are quite profound. Whereas if the person and family knew that they had a frailty syndrome, they would, if they became unwell, well, they would seek help early, and in the event of a crisis, they would have a care plan as to what might happen in the event, for example, of a fall. She might have been referred for a specialist clinic such as a memory clinic to look further at her cognitive impairment. She might have had therapist intervention sooner to assess her balance and gait and maybe provide her with a gait aid and prevent her falls. She might have had an environmental assessment at home. She might have had her medications reviewed. She would hopefully have had a personal care record, which could then be brought with her to the hospital, or indeed shown to the paramedics when they came to her house, in which case there would hopefully be a pathway that would provide for them not having to bring her to the ED. So the emphasis would be on ambulatory care and admission avoidance. Not because of lack of hospital beds, of course, but because of the risks associated with admission. And within the hospital, if she had been put on a frail elderly pathway on admission, then she would have had a comprehensive geriatric assessment on a specialist ward and would have seen a geriatrician and multidisciplinary team. And hopefully there would have been an emphasis on returning her home very quickly with supports and an enablement team. So what can we do about frailty? Well, we need to think about frailty. We need to recognise it and understand it. We need to do something about it when we see it. It needs to be everybody's business, and it needs an integrated and functioning whole system. And the standard of care in the setting of frailty is to have a comprehensive geriatric assessment, because some cases of some adverse outcomes can be prevented. Thank you.
Thank you, Christina. And we'll have time at the plenary after Martin speaks next for a really robust discussion. So I hope that all of you are noting your questions and keeping track of what you'd like to ask Christina along with the other speakers from this morning.
Great. Thank you. Thanks very much.
Oh, no. Sorry about that, David. I'm toggling and...
Oh, sorry.
Okay. You're the best. And here's Martin Dunn. So Martin and I have met each other over the years here in Cashel. And again, you can read about his biography, but one of the things that strikes me most about Martin is that he is so very present. When you're speaking with him, I think that you'll find this as individuals in a very large group as well, but when you're speaking with him one-on-one, you are very much in the moment with him. And one of the things that I'm hoping he's going to elaborate on was a little bit of a teaser he gave me. You know, what about emotional memory? What about emotional memory? And I think that emotional memory will take us to the place that we need to be in order to bring this morning together. So Martin, thank you so much.
I was just so fascinated this morning. Hello, everybody. So fascinated this morning by stories, the amazing, incredible stories of people's lives. And I've got a story for you. Can I tell you a story? This is quite a different story. It's a story that happened a couple of years ago. And about 6, 7 years ago, my phone went off. And I answered the phone, and there was a woman on the phone. And she was absolutely frantic and really distressed. And she said, "Can you help my daughter? She's in a really, really bad way. She's 19 years old. She's just come home again from a psychiatric hospital. She's been diagnosed with personality disorder, anxiety disorder. She has begun self-harming again. She will not leave her room, and she has anorexia. Will you see her?" So, no pressure. No pressure. So I agreed to see her. And we'll call her Aisling, not her real name. So Aisling arrived a couple of days later at where I work, and she was in the reception area, and she came down to the office. She was a tall, pale, emaciated young woman. Absolute loneliness in her eyes. So I invited her into the office. And normally what happens, this is anybody who does therapy or anybody who meets patients or clients, normally what happens is you invite them into your room and you say, "Please have a seat." And I offered Aisling the seat, and she just stood there. And she said to me, "So what do you do?" And I said, "How do you mean, what do I do?" And she said, "Well, I've been to psychiatrists up and down Ireland. I have been in and out of therapy. I've seen counsellors. I've taken medication. I've done A, B, C, and D, and nothing works for me. So what's different about you?" And I said, "Well, okay, I'm being interviewed here. This is a job interview, and I'm wondering if I get the job at some point." So I said, "Well, from a human given's perspective, we start from a very, very, very simple base. And that is, all behaviors are attempts at getting emotional needs met." A very, very simple concept. All behaviors are attempts at getting emotional needs met. And then she said, "Well, what are these emotional needs? How do you mean emotional needs? Can you explain these emotional needs? What are they?" And I said, "We are living beings. And we come into this world with a set of physical needs in order for us to survive. We need air, we need water, we need shelter, we need sleep, which is both a physical and an emotional need. So they are our physical needs that we need in order for us as a living organism to survive. And then hardwired into us, going back to our mother's womb, is a set of emotional needs. And these emotional needs seek completion in the environment, whatever environment we're born into. These emotional needs seek completion. They're all the time on the hunt to be completed and to be met in the environment. So some of these emotional needs are. We have an emotional need for security as human beings. We need to feel safe in the environment in which we're born into. We've got to feel secure in the location that we're staying in, that we're living in, the environment that we're in. And that emotional need for security is the bedrock of everything else that happens in our lives. If we're insecure for any reason as human beings, we're going to suffer major distress in our lives. So security in our lives as an emotional need is the bedrock. Attention. Attention is a bit like emotional nutrition. We have to give attention and we have to receive attention. So having attention met in our lives is vital for our well-being as human beings. So the emotional need for attention, to give attention and to receive attention, is a form of emotional nutrition for us as human beings, and it's vital for us. The right kind of attention is even more vital. If we're told that we're rubbish, if we're told that we don't count, if we're told that our opinions don't matter, that's kind of negative attention, and we will suffer distress. So the attention that we receive and the attention that we give, as much as possible to be positive. So positive attention and giving it. So listening and talking, listening and talking, listening and talking. Control and autonomy. An incredible emotional need, having volition over our lives. And the thing about all of these emotional needs, as I explained to Aisling, is that these emotional needs are as important when we're 2 years of age, 1 year of age, 20 years of age, 50 years of age, 90 years of age. The intensity of these emotional needs do not change because we get older. They're there from the time we're born until the time that we leave this planet. That's how important they are. So control and autonomy, having some kind of say over what happens in our lives, to be able to make decisions for ourselves as much as possible, to be able to make plans, to be able to see into the future a little bit. If somebody takes our control away from us and has all the say in any relationship, whether it's a personal relationship, whether it's a work situation, or whether it's a care relationship, we're going to suffer as human beings. So our emotional need for control, to have some kind of say in our life, is vital for us as human beings. And be part of a wider community. And such a wonderful, wonderful thing, because we as human beings, our brains are designed to be around each other. We are social beings, we are social creatures, and we need the company of other people. We need that because it balances our model of reality. If we spend too much time on our own or alone or away from people, our model of reality is a challenge for us. It becomes singular. So the connection to people is a vital source of our well-being. So connection to other people. Intimacy and friendship. Now, this doesn't necessarily mean that you have to have a partner in life. It just means to have this emotional need met. All it requires is that you have one person, just one human being in your life, that you can tell them warts and all. Listen, I'm having a dreadful day, and nobody's going to judge you for it. Having one person in our lives that we can be with and offload and share warts and all, and we're not going to be judged for it. A vital, vital component for us. Competence and achievement. Feeling competent about what we're doing. And it doesn't mean that a person has to be, a gold medalist. It doesn't mean that. It means that whatever we do in our life, whatever job that you're doing, whatever we do, that we feel competent in it, that there's a sense of achievement about it. So it doesn't have to be a massive thing. It's that we're competent, we're good at that, and we get respect for that. Privacy. Privacy as opposed to loneliness. Privacy is a vital emotional need that we have as human beings. Having a little bit of time out for ourselves, the 5 minutes in the day or the 10 minutes in the day, in which we can consolidate our own experiences, to consolidate, to just have a little think for ourselves, to say, do a kind of a check on ourselves. How are we doing? Am I okay? Is everything okay? So that little bit of time out for privacy in these emotional needs. And status. Status within social groupings. Again, you don't have to be a gold medalist. You don't have to have gone on the Camino walk. It doesn't require any kind of big thing. It is the hundred small things that we do within our days, and as all human beings do within our days, that make up our lives. The little small things, and feeling supported within that. And our status. We don't have to be a movie star, you know. We can be ourselves and get respect for that status, being respected. Meaning and purpose. And I know during the morning there has been a bit of talk about kind of meaning. And it's quite amazing how all the speakers this morning really, it's quite incredible, because I put some of these slides together several weeks ago, and now I'm thinking that they've already been repeated by people. They've already been talked about by people already today. And it's incredible, isn't it? I think you do something with the water or something, Mary. Yeah, group consciousness on the subliminal kind of level going around in the ether is that ideas coming together. So the idea from a human given's point of view, and this would fall into Abraham Maslow's kind of thing of self-actualization and his stuff, which is meaning, finding meaning in life. And being stretched is a fantastic sense of meaning and competence in achievement. So what does being stretched means? Being here today is a fantastic stretching experience. Certainly from being here this morning and listening to the other speakers, my mind is already alive with some fantastic ideas and different ways of seeing things. That's stretching the brain. That's really stretching the boundaries. The very fact that we're all here today, we're being stretched, we're being challenged, we're being given knowledge. It's getting us to think about different things. Our brains absolutely love that. Our brains are designed, what's on the other side of the hill? We want to know. The whole history of humankind has been about endeavor and cooperation and seeking what's on the other side. How can I make it better? So finding a meaning in life. And also a purpose in life. A purpose in life. For some people, this is a spiritual belief. For some people, this is the religion. For some people, it means different things. But the concept behind this purpose in life is that there's a bigger reason to our existence as human beings. And this is the one. We were talking about suffering last night. And this is the one, having a purpose, having a bigger picture in life, to see a bigger picture in life, that perhaps we're here for a bigger reason. Having a spiritual belief, having a religious belief, or just being who you are. It has a buffer against suffering in life, particularly when it gets really difficult in life. It has a real buffer against suffering, having a purpose in life. It allows us to take the helicopter view rather than the worm's view of life sometimes. It allows us to take the helicopter view so we can see the bigger picture. The map is not the terrain. So I said to Aisling, well, these are these emotional needs, and part of what I do as a therapist with human givens is to listen to what you have to say, and through that, hopefully, to pinpoint what emotional needs are not being met in your life at this moment in time. And if at all possible, then to put in tasks, situations, or if there's any way that I can help you to get these emotional needs met in balance. So with that, thanks be to God, I think I passed the interview. She took off her coat and she sat down in the chair. And it was then I noticed huge, great big chunks taken out of her arms, and she had some bandages on, and she just sat there. So for the next couple of weeks, I worked really intensely with Aisling. And after several weeks, because I would always see the therapy that Human Givens does is very much a collaborative thing, is that we can make talk about rapid changes and bring about different frames of reference within the therapy room, but a lot of the work then is up to the person in their lived experience, in their lived world, to help with this. So it becomes a collaborative two-way process, the whole therapy process. And after a couple of weeks, the self-harming had ceased. And she began to feel a bit better about life. But lurking in the background was anorexia. And every time that I tried to mention or come around to the subject of anorexia, she would completely clam up and say, no, that is absolutely a no-go area. I don't want to talk about eating disorders and I don't want to talk about anorexia. As a matter of fact, she said, every time I think about food, it makes me ill. Every time I think about food, the very thought of food makes me ill. That sentence was to prove very, very poignant later on in our work. Every time I think about food, it makes me ill. So it was kind of a dilemma then after some weeks. She was doing so well is that the self-harming had reduced and ceased. She was getting out a bit more. She was feeling good about life. Her emotional needs began to be met in her life. And she was feeling much better. She was sleeping much better. She was calmer in herself. But in the background was this anorexia. And that was a dilemma for us, I felt. If the anorexia was to be left there unaddressed, would it in the future sabotage all the brilliant, brilliant work that this young woman had done? Was it fair to leave it there? And I'll come back to Aisling's story a little bit later, if that's okay. So anorexia nervosa. And this is the first case of anorexia nervosa, Miss A. And these come from the medical papers of Sir William Gull in 1874. So it was the first case of anorexia coming in as a clinical kind of thing, a disorder. So anorexia, again, was first diagnosed in 1874. The term anorexia was coined by Sir William Gull in London, 1874. And there are over 200,000 people in Ireland suffering from an eating disorder. And that's just kind of an estimate. I reckon there's a hell of a lot more than that. So the diagnostic criteria then, the DSM, as you well know, is the diagnostic manual for psychiatry. So the DSM criteria for anorexia nervosa is a restriction of energy. You can read it there. And the intense fear of gaining weight and becoming fat or persistent behavior that interferes with weight gain, even though there's significant low weight. It's this conflict all of the time within anorexia. It's the conflict of thinness and fatness, weight gain and weight loss, the conflict within that. Okay. So anorexia nervosa then reflects a mix of environmental, social pressures, family dynamics, body dysmorphia, which is very much how the person views their own body. Looking in the mirror, even though they're incredibly thin and emaciated, what is reflected back is somebody who's overweight and fat. The distorted image. And a possible genetic predisposition. What I find quite incredible about anorexia, and the reason why it'd be top of the pile, is that the mortality rate within anorexia is huge. It is huge. That is 10 times higher than for the general population. This is mortality. 10 times higher for the general population and 3 times higher for those with other psychiatric illnesses. So it's one of the biggest in psychiatric illnesses on top of the pile on which people have a mortality rate or die from. It's incredibly hard to treat. So some of the behavioral and emotional symptoms of anorexia. So the preoccupation with food, obviously. fear of gaining weight, depression, and thoughts of suicide. There's been a huge amount of research into kind of the driving kind of underlying kind of things behind anorexia. And that's perfectionism. Perfectionism was first coined by Hilde Bruch from the 1930s. She's really one of the world experts. She's left us now, God be good to her. But she wrote extensively on anorexia. And she noticed this underlying kind of thing within anorexia, which was perfectionism, which is this drive to be perfect all of the time. It's almost like bordering on obsessive compulsive disorder. So it's a perfectionism in everything. And it's that kind of agitation within the person, that drive all the time for perfectionism. Hyperactivity is a common feature among anorexics and bulimics, is the inability to sit down for 5 minutes. They're constantly on the go. Constantly on the go. And some will walk maybe 20, 30 kilometers every single day. And it's constant exercise. Even when they're in treatment in hospitals, they will walk and pace the wards. They will walk and pace the rooms that they're in. So hyperactivity. And this drive for thinness, the body check and dissatisfaction, and ineffectiveness. And this was another thing that Hilde Bruch, way back in her work, found, that there was this sense of hopelessness and meaningless kind of thing about people with eating disorders, particularly anorexics, is this ineffectiveness on life. It doesn't matter what I do, there's nothing coming back. I'm making no impact. And it's this kind of depressive kind of thing of it being ineffective. And I think this is really, really important, this last one, because it has relevance to what I'm going to talk about when we talk about our older people. Is the inability to distinguish bodily sensations from emotions. Anger can be confused for fullness. And this is really an amazing kind of breakthrough, really, in treating anorexia. Because the inability to distinguish a physiological state, my leg is hurting me, from an emotion. Now, we can do that. If we stump our toe, for example, we can do that quite readily, can't we? We can do that. We know the difference between pain and an emotion. So there's a physiological feeling of something that happens which is absolutely separate from an emotional feeling. And this is one of the things that's really becoming to the fore now in treating people with anorexia and bulimia. And one of the great things that they've discovered, which is really effective, which is as old as Buddha himself, is mindfulness. Is mindfulness. Is getting the person to sit there and become physically aware of all their tissue, all the muscles, all the bones, and that gives them a sense of awareness of their physiological state. And I found it to be incredibly effective. Bit of mindfulness with somebody. So that then the person can distinguish between an emotion and a physiological kind of thing, which feeds into, for want of a better word, feeds into the feeling of being hungry and being full. Two different kind of feelings at work. Are we okay so far? Yeah. So bulimia then. So the reason why we're taking anorexia and we're taking bulimia is that these are the big hitters when it comes to mortality and the hardest kind of things to treat in therapy or in hospitals. Bulimia first entered into the diagnostic books in 1979. And its core feature then would be bouts of binge eating and purging. Binge eating and purging, and the use of laxatives and so on. And people who suffer from bulimia tend to be a bit older than anorexic. young women. And it's mainly young women. That's not to say that young men don't suffer from anorexia. They do, but they're on a small percentage in comparison to young women. And sometimes they can be diagnosed at age 11 or even earlier, all the way up. So people with bulimia then tend to be diagnosed a bit later in their 20s. Are we okay in that? So elderly anorexia. This was to give you a kind of a thing of where the concepts of anorexia, where the concepts of bulimia came from. And I have a question there, is what is elderly? And I ask myself this question, and I throw it out as a general kind of thing, is that the terminology sometimes that I use, and I've heard people in the outside use, is a distant kind of cohort of people on the periphery. Geriatrics, old age, elderly, seniors. It's almost like a distant kind of tribe of people, almost. Whereas, in fact, what we're talking about is our future selves, isn't it? That's what we're talking about. We're talking about this whole conversation today is about our future selves. So for the purposes of the literature then, midlife is defined between ages 39 to 59, and elderly or later life is defined as 60 or older. That's for the purposes of the literature review. And anorexia is defined as a loss of appetite and of reduced food intake. And according to Morley, anorexia is a true geriatric syndrome. So elderly anorexia, although it's different from the perceived notion, and to be totally honest, when I first came to this, it was at the impetus of Mary Prendergast, because my focus as a human givens therapy over the last couple of years, I've been very much involved with people with eating disorders. It never really occurred to me, I'd heard about it, but it never really occurred to me that it required serious discussion and serious conversation was elderly anorexia. I was so focused and so blinded by the cohort of the perceived notion that anorexia can only affect the younger population, and that's what it was all about, that I'd left my... Or a mercy, I will take it as a learning experience. So it's most commonly associated with the younger generation, but the latest research then shows that it's likely to occur in the elderly. And one little study that was done of 475 community-dwelling elderly women in Canada, aged 60 to 70 years of age, found that 3.8% met the diagnostic criteria for eating disorders. And many older people experience, and this is about appetite then, a decrease in appetite. This decline was first described as the anorexia of aging in 1998 by John Morley, who we saw earlier on. And there's some more work from Morley in the UK. Okay. I don't know whether I skipped one there. Many older people experience a decrease in appetite, blah, blah, blah. Yeah, we got that. All right. Okay. Reduced appetite then could lead to reduced food intake, nutrient intake, increasing risks of weight loss and nutritional deficiencies. And what they're basically saying, what the literature is saying is that when the elderly or older people lose weight, it's much harder to put it on. It's much harder to put it back on again. And I think this piece of research kind of gave people a bit of a shake-up. And it was Hewitt and his colleagues examined over 10 million deaths in the USA over a 5-year period and analysed those in which anorexia was a primary cause of death or a secondary condition present at the time of death, they found that 724 records that listed anorexia as a cause or condition of death, and they found that the majority of the deaths were due to anorexia, of anorexia were in the elderly. And that kind of woke people up a bit, that kind of study. It got people really thinking about, we should be looking at this in a different way, you know, that there's something going on here that needs investigation. So another part of the literature review then was 48, and these are published cases, respected academic published papers across the spectrum. 48 published cases of eating disorders in people over 50 years of age. And what they noticed was, and I'll come to this in a second, is that late onset of eating disorders were more common. And the comorbidity, which is my field, the comorbidity of the psychiatric condition existed. Most commonly, major depression. So depression seems to be a common factor among all of those. Okay. The clinical features then, I'm rushing now. So early onset then, which continues or reoccurs in old age. What they reckon in the literature is that in the early anorexia, what happens is that it either went untreated or life got in the way in the intervening years. Families, children, careers, work, all of those situations got in the way. And then when stressors came later in life, certain stressors, that was the trigger that set off the reoccurrence of an eating disorder. Or late onset, which developed for the first time later in life, which Morley talked about. So there's a psychological difference between the younger population and the older population. Okay, and some of that would be the age and physical appearance with age-related body changes, familial relationships. The need for control, we're back to those emotional needs again. So the need for control and attention, gaining control over loved ones. Sometimes food being used as a protest, being used as a commodity of protest. And as we know, with emotional needs, all behaviors are attempts to get emotional needs met. And again, coping with stressful life events, control, bereavement is a massive one, isn't it? Health problems, mobility problems, loneliness, hearing problems, massive, ill-fitting dentures, depression, loss of meaning, anxiety, dependent on other people all of the time. What is that saying to us about emotional needs? That's taking our autonomy and our control away, isn't it? So there's always two sides of the story. There's some people who believe that anorexia is not a thing of the older generation. It's not. It does not exist in the elderly. And people who are into studying eating patterns of the elderly point out that there's possible other explanations of why it would be considered anorexia. Anorexia. Are you okay? Are you okay? We have loads of nurses here. So they reckon that there's a biological explanation, palatability including food texture, so the biological thing, the fullness signals, okay, so the biological, palatability. And somebody talked about this earlier on, about people not being able to afford things, poverty, and economic factors, social factors, access to food autonomy levels, people not being able to either afford or to be able to buy the choice of food that they want to cook and to eat themselves. It's all ready-made stuff being handed to them all the time. And again, we're back to the psychological factors such as depression. Okay? So the health thing then. So there's illnesses, heart problems, breathing problems, dementia, far better experts on dementia than I am. Pharmacological treatments, I think one of the speakers was talking about when there's a combination sometimes of different medications in a person's kind of daily intake of medications, there can be a clash which can cause a reduction in appetite as well. And the physical signs then, low weight, body temperature, the skin, the hair, constipation, fatigue, irritability, changes in behavior, disappearing after a meal, for example, wanting to eat alone all of the time, and the use of laxatives, perhaps, in the rooms. There's a really good screening thing I came across, which I think is really, really brilliant for older people. And it's a five questionnaire screening tool, and it has a sensitivity of 18.46, which I believe is very high. And this can be found on Morgan et al., or the Medical Journal Publishing Group. And it's specifically designed for the cohort of people that we're talking about. I'll just go back. Can I go back? Just back to the last one, please. Brilliant. So the recommended thing is, and this is the cautious kind of approach to this subject as well, is a comprehensive physical examination and medical evaluation are essential to rule out physical or medical causes of unexplained weight loss before assuming that an eating disorder to be the cause of the problem. So that's a pretty wise thing, isn't it? A psychiatric evaluation should be screened for the common disorders associated with weight loss, depression, anxiety, and cognitive disorders. I'm going to run ahead here. So the emotional needs then, what we talked about earlier, are the emotional needs of the individual being met in balance? So I would always be watching and listening for what emotional needs are not being met. What behaviors are being displayed that would lend me to believe that there's an unmet emotional need not being met in that person? And can I address that? Do we listen more than we talk? Are our needs as carers and as practitioners being met? That's really important, because when our emotional needs are being met, we have the spare capacity and the spare energy to be able to help others and to work with others, so that our clients don't become, or our patients don't become, a gateway into us having our emotional needs met. That we are robust enough, we have our emotional needs being met in our own lives, so that we can give 100% to our clients and our patients. And I have that there. Is decision-making when emotionally aroused always clear, and does it produce best outcomes? When we're emotionally aroused, we don't be thinking straight because the logical brain is knocked out of kilter. We're not thinking straight when we're emotionally aroused. And the only way really to make proper decisions that provide best outcomes, particularly for the people that we work with, is not only to calm ourselves down so we're not emotionally aroused, and to calm the person down in front of us. We were talking earlier on how you wouldn't talk to somebody who was angry about, tell me all about your anger. They only make them more angry because the pattern is running around, the video is running. So you'd calm the person down. Calm down. Now let's have a look at this anger. Now let's have a look at this thing. Now let's have a look at it. And is there an ethical dilemma by not addressing the elephant in the room? And this is a question that I had to ask myself. I'll come back to Aisling now. So, she'd done fantastically well, Aisling. She had, self-harming had stopped. She was getting out more. Her emotional needs were being met. I asked her to, because she was interested in art, I got her some kind of outward kind of mobility to visit art galleries and stuff like that, part of the tasks to get her re-engaged with life and so on. But still the anorexia was there. And any time I tried to mention it, she wouldn't have it. She was not talking about it. Tim Bond, we were talking about ethics. The speaker was talking earlier on about ethics. Tim Bond, who writes on ethics and therapy in the UK, talks about situations like this, and he poses the question, whose dilemma is this? Whose dilemma is it? Is it your dilemma or is it the client's dilemma? After you've provided them with the best information available and the best health care that you possibly can, whose dilemma is this? And it's a very interesting question. And I sought tons and tons and tons of supervision on that very question. And the answer really came back to, would not looking seriously at the anorexia sabotage all the amazing work that this woman had done? And in my opinion, it would have. So I decided to go for it head on. But because she wouldn't talk about it, and because she had said something earlier on in the therapy, which she said, every time I think about food, it makes me sick, it makes me ill. That stuck with me, because I'm very interested in emotional memory and how emotional memory works within human beings. Is that I believe that all our experiences of human life are tagged with emotions. You just have to turn on the radio someday and hear a piece of music to the first time you fell in love, and off you go. It transports you back there, doesn't it? Or you taste something that you haven't tasted in a long time, and it brings back memories. Or a bag of chips on the seafront. All of those memories. So some of the memories that we have are tagged with positive tags, and others with negative tags. I tried to do something with Aisling, which was an experiment, and she agreed to go along with it. I had her permission. What I did was, very, very quickly, I know I'm rushing now, I asked her to think of a really beautiful place where she'd be absolutely relaxed. And she said, the garden at home in summertime is the most fantastic, beautiful, spectacular place in the world. There's beautiful roses, the grass is cut, and the sunshine is there, and there's a beautiful chair, and it's surrounded by little bushes, so I'm hidden off from the world, and it's just so private, it's so beautiful. And I said, let's go there. Let's go there. And I will be the guider of your imagery. In other words, that you choose the location, and I will guide you there, and I will suggest certain things. So she got very, very relaxed, and I suggested she'd visit her garden, and she did. And I said, well, you can smell the beautiful roses now, perhaps. Or you can feel that sense of warmth of the sun on your shoulders. You can perhaps hear the sound of the birds singing. And the imagery was being guided. And she was getting really, really into this and really relaxed. And I could see her. She was just sinking into the chair. And then I said to her, what fruit would complement such a beautiful, perfect location? Now that you're feeling so wonderful, now that you're feeling so relaxed and so happy, what fruit would complement that? And without even thinking, she said, strawberries. I said, fantastic. I said, imagine now there's a bowl of strawberries in front of you, and take one out, Aisling, and have a taste of it. And she said, oh, God, I could taste it. It's lovely and sweet, and it's beautiful, and it's just fantastic. And then I asked her then to remember an autumn scene, and then a spring scene, and so on. So we had 4 different kinds of fruits for the 4 seasons. And when she got home, I asked her to get out pictures of the 4 seasons and to replicate that experience that she'd had in the therapy room of looking at these beautiful pictures of the summertime while eating fruit. What we had done between us is that we'd reversed the negative memories associated with eating. We'd reversed them because now we had found a positive, happy memory associated with eating, so that the season that she was experiencing as a really positive, happy place, the food was a complement to that. It was a complement to that. And we made huge strides after that. So I heard from her mother. We finished in therapy a couple of weeks after that. I put her in touch with a nutritionist that I know who understands the human givens approach and what we try and do in therapy. She agreed to take her on. She took her on. And now Aisling went off to art college. And her mother phoned me about 6 months after, checks in with me every so often. I get a card or something, and I say, how is she doing? She's doing brilliant. She's grand. She's absolutely fine. I'm a passionate believer in using the resources that the person has, particularly emotional memory. Milton Erickson, a famous psychologist from the 1950s, said, in order to get connected to a person, you must enter their model of reality. Somebody was talking about that earlier on, about heading into your mother. Fantastic. I am a total believer in that. Milton Erickson said, to connect with somebody, you've got to enter their model of reality. Don't fight them with your model of reality. Enter theirs. What a fantastic thing. Now you have a cooperation. Now you have two things going on. So very quickly, emotional memory then, taste, smell, and vision. And I've tried this with some of the older people in our community as well, and it's working very effectively with them. So it doesn't have to be a sense of a garden, it doesn't have to be that. It can be stories, objects, photographs, something that has a positive memory for the person that you're working with. And associating a food with that positive memory. So music, as we know, places, people, the personal and intimate histories can reveal a person's connection to positive memories and emotion. And my own experience is that it really, really works if you allow yourself the time to do this with people that you're working with. Let that go. And I will say thank you. Thank you.
Okay, and then all right, so that part wasn't recorded, the play with opportunity. So now that we're back on the recording, what I'd like to ask the audience is, what are your top questions for our speakers from this morning? Who's got a question? And Mary has the microphone, so don't be shy in raising your hand.
Well, if I could start with,
yes,
with Patrick. No, I just, something occurred to me while you were speaking in terms of what you said about vocational practice and the whole idea of service. And from a hospital point of view, we have always advocated that giving back a little, sometimes we get rewarded in many ways as well. Not to count that as a negative, but really as a positive way of looking at life in general. And I loved your idea about that interconnectivity with people and dependency. And I just wanted to know, if you were to advise something to a team, how to integrate that in practice, what would that be?
As a psychologist, I don't like giving advice. And now to contradict myself, here's what I'll say. I mean, go back to that notion of the two eyes on two eyes. So in developmental psychology, when we try to understand what happens to us as we mature through the decades, we have this little phrase called reciprocal interaction, and it essentially means that whatever I do influences you, and what you do influences me. And that's at the biological level, it's at the spiritual level, it's at the emotional level, it's at the cognitive level. So there are exchanges happening all the time. Normally, we're very busy and we miss out on them. So in terms of ensuring that you are rewarded and sustained and nurtured in your work, it is about, even at team level, it's about being able to grab the evidence for what's happening in all of those interactions and never discount the ordinary. So we tend to look for big moments in order to define almost how somebody's life is or isn't. But it's the ordinary interactions. So what was it like if you sat on the end of the bed for 20 seconds with a frail elder? What was that like for them, and what was it like for you? And let that become the evidence base out of which a multidisciplinary team makes its decision. All of the information, not just the big events, not just the negative, the distress, the illness, the disease piece, but all of the information, all of the data is relevant in terms of developing an understanding and a conceptualization of somebody's presentation.
Thank you very much. Anybody else like to ask a question?
Yes.
Sorry. I work in the acute hospital sector, and we won't go there really much. University Hospital Limerick, lovely university and very crowded hospital. And I just wondered from the panel's view, and I'm not sure which person to come to. I know from the gerontology, maybe that's one of the areas for the consultant, but I think how can we help families to actually help those people that are frail in hospital and to advocate them in a way that the people in the hospital can work with the family, because we're really at that stage, just we can't do it at the moment under the pressures we're in, even though we should be doing better. So the advocates will be the family, but they often seem to be forgotten. If you could.
So perhaps we can ask, beginning with Christina and moving across the panel, for what the first thing that comes to mind in engaging the family in the acute care setting. Thank you for that question.
Family to engage.
Yeah.
Us
Yeah.
them,
Yeah.
To be honest, because we don't always do that. How can they
Guidance
know how to work with
for the family in that relationship. So starting, Christina, would you like to start with that?
Sure. I suppose then you might ask, what are the barriers to the family engaging? Is it because hospitals are very busy places? You know, you have to drive in, park your car, walk a long way, pay for your parking. Are there just factors like that? Also, because of crowding in hospitals, it's very difficult to spend very long. That would be my own experience visiting relatives, because you feel you're in the way. You might be visiting them on a corridor. You might be visiting them in a very noisy environment. Then there are visiting times, and many hospitals try to enforce those, don't they? Because to give patients time for rest, and also from an infection control point of view, sometimes visitors are restricted. However, my impression is that families are quite keen to get involved when they're allowed to get involved. One of the quotes that I had on the slide, I didn't read that particular quote, but it was a man who was talking about his wife not eating in hospital and progressively losing weight, and he wasn't allowed to stay for meal times because that was the rule. And when he came after lunch, he found her tray with the food was still there, and it was too far away from her, and he insisted on being allowed to stay for meal times. So maybe we have to change the culture of how we engage with families. Everybody, as you say, is very busy, and so who actually stops to talk to them, and how do we bring them on board more? But there must be a way of doing that.
Great.
I think it can be done, you know, whether it's through something simple like information that's given on admission to a family and to a patient, an information pack about what to expect in hospital, and to inform them that they're very welcome to come and that we'd like them to be involved more. I don't know, I might pass on to
Other
others. I'm sure others will
panelists?
have another perspective
So
on that.
changing culture is a highlight. Other brief thoughts, the first thing that comes to mind?
Oh yeah, my situation would be completely different. I start off with the idea that if somebody is either physically unwell in the family or has emotional or mental health difficulties, is that everybody's affected within the family. And I would most certainly in my work would see families on their own away from the patient or the client. And I would ask them how they are, how they're feeling. And it's a recognition of the burden that they're carrying and the amount of effort and work that they're putting in. And I would always try and include them in decision making as well, and to ask them, is there anything that I can do to help them? In other words, that they feel included in the process, and the work that they do is respected and acknowledged. And I think it goes a long way to helping people to have the energy to keep going, because they're being listened to and they're being acknowledged. Certainly it's worked really well in kind of what I do. I'm not sure how it works in a multidisciplinary kind of setting in a hospital, but that's how I approach it. We all need to be recognised, whether we're carers or whatever. You know, our emotional needs are just as important as the other person. We're all equal in this stuff. Yeah.
Patrick?
I think there are wonderful lessons to be learned from the intellectual disability sector. If you think back over the last 30 years and the promotion of advocacy and formally bringing together people and giving them platforms on which to turn some of their anger at the services into a voice and into action that actually would be useful for them and for others. I think there's a lot that the intellectual disability services have done really, really well in bringing in advocates, family members, carers, that could be used just generally in the health system. So it might be worth looking to that sector also.
Great, thank you, Patrick. Dana?
And I would zoom out to that largest political framework and think about how is it structurally set up to close out families? I mean, think of how HIPAA regulations are so individually focused, and what we need is to have hospital admissions, doctor-patient conversations all be more family focused, especially when we're talking about people who are frail and who one of the criteria for them being in good shape is that they have family support. So we need to rethink this individuality focus altogether, and then it could change in terms of, as you mentioned, the hospital visiting hours and so forth, but just basically the opportunity for family members to be ever present and their knowledge to be valued every step of the way. Then they'll participate instead of feeling like they're shut out from it.
And HIPAA is American Health Privacy Law.
Someone mentioned it here, so I said, oh, I didn't know you.
Yeah. HICWA is different.
Oh, okay.
Yeah.
Is it the same?
No.
I heard wrong.
Yeah.
Oh, darn.
Just doing translation.
Yeah.
That's great. Thank you.
Yeah.
And I think we have time for one last question. Yes.
Thanks. Richie Malay is my name with Family Carers Ireland, and this was just taken up, the point that the lady mentioned. We're an organisation that advocate for family carers, but most carers that come into us, I suppose they have a huge fear when their loved one goes into the hospital setup, because they feel that they're out of it then, despite all the knowledge and the experience that they have. Now it's over to the hospital. A big problem then is who to ring in the hospital for information. You ring in, the person say, oh, they had a good night. They don't, very little information given. That maybe if there was some way of involving the voluntary organisations as advocates to be in the hospital, that they'd almost interpret the services, because when the person is admitted to the hospital, the family carer knows who, the different floors, the different doctors, and as you say, it looks like it's a hive of activity. You're in the way, more or less, and that creates tensions and stresses on the outside. And if I could just take the opportunity to mention, we have a carers forum in the morning in Hotel Kilkenny. And I suppose I just said to people that might be in the room here, if you are a carer or indeed a former carer, you'd be welcome to attend that, and we have transport going from Clonmel to the forum. And the idea of that forum, again, is to allow carers to come together, discuss this type of thing, and then to see how do you go about lobbying to get those changes brought into the hospital setup. And well done again on this morning. Thanks, Mary.
And Mary?
Special preferential treatment.
There
here
you
from
are,
Mary.
Mark.
Dan,
Dr.
my
Mark
question
White.
is for you, and there's two parts to it. The first is in relation to stories, and I'm wondering, I was left wondering after you spoke how much you were guided by, I think you said you're a medical anthropologist, so how much you were guided by stories from your training or from your family, and whether your mum actually was rich in stories when you were growing up. So that's the first part of my question, and I think I'll answer, that might even answer the second part if you...
Okay, my mother was always a book lover, and she read to us constantly when we were young and took us to the library, but she wasn't really a storyteller. So and I was a wild reader my entire life. I used to stand next to the tall windows in my bedroom to read by streetlight. But it was really the anthropological training that made me look at medicine differently. So instead of just getting in there and saying, oh, she's got this disease, I looked at it and said, it's a system of beliefs and practices, so I need to enter into understanding this through a different medium. So anthropologists are trained to listen, and then we're trained to keep track of all those qualitative data and then put them into a framework that makes sense of them. So that sort of set me up for how to think about it, and I could have written an academic paper about it, but I didn't want to just talk to other academics. I wanted to give it to caregivers. I wanted to give it to families. I wanted to give it to patients. And therefore it had to be in the form that was most accessible, and that's stories.
Okay, and then the second part of that question then is, in many ways, then your lens and your perspective is, you know, it's unique. Firstly, because it's your mum,
yeah.
But secondly, it makes it very difficult for professionals who get trained in one lens, like nursing, to then adapt or adopt the view or perspective that an anthropologist would have. And whilst it's really, really insightful and you left you with a great experience because of the experience and because it was your mum, it just puts an onus on us as professionals then to maybe think differently, of which doesn't come naturally when you're trained in one particular biomedical type model.
Sure, that's a great question, and it really highlights how each profession has its own culture, its own set of rules. I think that the task is really pretty simple. It's just to translate from one culture to another. Nursing is just filled with a value of the whole person and of humanism and of valuing them. And so, it's really just a simple step to start then saying, well, wait a minute, we need these stories as a way that we can incorporate that right into our daily work. I don't think it's an impossible barrier. I mean, if I were teaching a workshop, we would do something here and everyone would start writing a story, because you're all walking around with these stories that haunt you about your experience as caregivers or your experiences as professionals in the workplace and so forth. And so when you get into a storytelling framework, it's essential to reflect, and it ties back into what both of you mentioned, that caregivers, professionals have to take care of themselves. And I think by becoming very acutely aware of the stories of how your interactions with other humans impact you personally, then you're better able to go out and care. So I think it's just a matter of a little bit of translation and going how to make that very kind of, oh wait, this isn't what we usually do in conferences, connect to actually what you do every day in your jobs.
And there are a number of models across nursing that have used anthropologic techniques to do that in clinical practice. So happy to share some of those ideas for any of you who might be interested in that as a complement to draw out the best of science and to shape the nature of our care. Yeah. Okay. Oh. hold on for 1 sec. We'll just ask you to.
Sorry, beg your pardon. In order for that to happen in the areas that it has occurred, has there been an increase in human resources? Because in order for, you know, we see human resources in our current nursing climate is at an all minimum, and therefore very difficult to be able to give that time.
Yeah.
And it's about time, and it's human resource time.
It's actually about
very poor in that at the moment.
Really wonderful question, and I'll be very brief because we do have to get lunch. We have to take care of ourselves in eating lunch. It's actually about narrative time and pivoting your orientation so you make best use of time. So I'm going to leave it at that. Encourage you to care for yourselves for about the next 45 minutes over lunch, and we'll come back together as close to 2 o'clock as we can. Thank you.